we've got the next panel, and I think without further ado, we'll move to them. A very distinguished panel. We've got Luba Greenwood of Harvard. She's joined by John at Georgia Tech, Ray from Bright MD, and Victoria from NYU Presbyterian. All of these folks have PhDs and/or MDs. So it's a very, very impressive group. And we've asked Luba to moderate, give a perspective on what does all this mean from the standpoint of the practitioner and the provider. So Luba, without further ado, hand it off to you.
Great, thank you very much. Can you hear me?
Yes.
Excellent. We do, as you mentioned, we have an excellent lineup today of real experts in this field. We have Ray Constantin of Bright.MD. We have John Duke of Georgia Tech and Victoria Tiase, if I pronounce this correctly, from NYU Presbyterian. So first, I would like to take the opportunity for each of the participants and panelists to introduce themselves and to tell us about their organization and also what, if any, effect, just very generally at the beginning, the new rules for interoperability have on their organization. Ray, should we start with you? Nope.
Bright MD, and hopefully everybody's able to hear me here.
Yep.
One of those funny things about virtual conferencing, got to check in on those sort of things. So quick background on me, internal medicine trained physician, helped build and lead the digital health services group at a large West Coast healthcare delivery system before starting Bright MD. What Bright MD does is automate the care delivery process, making it 10 to 15 times more streamlined for clinicians to be delivering care for currently about 50% of primary care visit volume. And so integration into the EMR system is a critical part of what we do and how we help deliver on the value that patients, providers, and healthcare delivery systems expect from that kind of a platform. And I will tie this into a very timely situation as we move into a increasingly, I think it was officially declared a pandemic, our ability to be able to implement more quickly through improved standards becomes a really important part of how we can not only help over the long term, but how we can be more adaptable and help delivery systems improve their clinician capacity and serve their patients' needs more quickly. So a very timely tie-in between interoperability and current events.
Absolutely. Thank you.
Absolutely.
And who else? Do I see? Hold on, I'm trying to see who. John, looks like we have you there. Oh.
Yes.
Okay.
Victoria, do you want to go next, and then John?
Victoria, yes, or Victoria. Oh yeah, there's Victoria. I see you now. I've expanded my. Okay. Hi, Victoria.
Terrific. Hi. Good afternoon.
Hi.
Thanks for having me. So my name's Vicki Tiase, and I'm at New York Presbyterian Hospital in New York City. And although I am proud of the PhD, I'm very proud that I'm also an RN, so I bring the nursing perspective to our patient-facing applications at New York Presbyterian. We do a lot of work in testing our patient, evaluating, I should say, our patient-facing applications. I've worked very closely with New York City in the Digital Health Accelerator programs, so we've had some great testing with new applications and new vendors. And I also want to mention, in wearing another hat, I also serve as a liaison to the Karen Alliance. You heard from Ryan Howells earlier, for the Alliance for Nursing Informatics. And there we are thinking about how we mobilize nurses to support patients in thinking about these new rules that were just released. So I'm excited to talk about that aspect of this. Thank you.
Well, thank you.
Wonderful.
Very
Thank you,
much.
Vicky. John, hi.
Yeah. Hi, Luba. Thank you. My name is John Duke, calling in from Georgia Tech. I appreciate being here. I'm also an internal medicine physician. I lead our Center for Health Analytics and Informatics. I think what is, from my perspective, we do a lot of work with CDC and FDA and other agencies related to understanding public health and safety. And so for that purpose, interoperability and FHIR in particular has played a very big role. But we also teach, right? I lead a course in health informatics and interoperability here at Georgia Tech, which is has over 500 students a year, master students coming through. And I think that the new rule is, of course, going to have huge implications for our ability to consistently deploy standardized approaches, but also from a perspective of educating students about this, we're able now, I think, to say we've moved clearly from a point of people are sort of learning about the next generation of what's coming to this is now on the ground, we know where to go, and that these students coming out are basically learning what they need to know to work across the healthcare field. So I think there's also very significant workforce implications of the new rules as well.
Excellent. Well, thank you, John. Thanks. Well, I'd like to dig in actually in specific. Vicky, you mentioned you're Presbyterian and you're involved in so many different initiatives. I'd love to really understand how does it affect the organization, and also more in particular the nursing, basically the nursing staff and how they do their work. I'd love to hear about that.
Absolutely. Thank you. I think we heard a lot throughout the day, some terrific information about the technical aspects, but I think the other important piece is the operational aspects of this. And we have been working at New York Presbyterian in a couple of areas, and actually in light of COVID, also thinking about how we support patients in their questions, in particular to the patient-facing applications. So we've done some work with our nursing staff in understanding their readiness as the front line in interacting with patients and families. And we recognized very quickly that there is a need to support and provide our frontline staff with the educational materials and tools to answer the questions from patients and families. We certainly now anticipate many questions around security, around APIs, and what that means. And I think ensuring that we have the policies and procedures in place, and as I mentioned, the educational side of it as well, is going to be very important as we move this forward.
That's great. And can I ask you actually on that, right? So you're sort of in one of the epicenters of COVID, right? You're also I visited New York Presbyterian last year, was very impressed with your facility. But you are really right there in the middle of New York City and serving such a wide population across all the boroughs. How is it, anything will be changing at all, you think, especially with this new rule, and how quickly, right? And what do I mean by that? We're all here at home, right? We're not in person meeting, and this is happening real time. Do you see that we can do something quickly as practitioners, right? What can we do for our patients that are stuck at home, that are coughing here and there, and they're not really sure? Is it allergies, right? You see warm temperatures right now across West Coast, East Coast, the rest of the United States. Is there something that is happening real time right now with respect to just digital health and telemedicine all together and improvement outcomes, and if at all this rule is helping?
Yeah, no, those are great points. I would say, one, we have found that, at least from our patient population, they'll absolutely welcome this. They are more than interested to get their health data. So I can say that the need and interest is there. So from that perspective, that is super helpful. And I would say, let's see, I think it's going back about 3 years now. We actually talked about this at HIMSS as a best practice initiative. We started a helpline for our patients using our portal, our personal health record. And we had staff 24/7 available to answer patient and family questions about their portal and their information. They could tell us if there was something wrong with their information, if they wanted to contact a certain provider about something that they saw, we would, broker that that contact. And I think that has really put us in a good position to start thinking about the next steps. How do we scale that? And, as you mentioned with what we're dealing with today, one of the first things we did at New York Presbyterian was put out a hotline for our patients. So we know that having that quick response to contacting patients, answering their questions is really crucial. And I think, moving forward in this new, with the new rules and patients being able to access their data, I think we're going to expand that even further. And I think that will be very important, meeting the patients where they are and answering their questions, whether it be, through emails or texting or a phone call. So looking at the patient preferences is going to be essential.
That's great.
That's
I know, Ray, I see you're nodding. What do you think?
Oh, I completely agree. I think this, particularly in these moments of increased need, is really important. And I think while we can't wait on these changes that are coming in terms of interoperability and increased standardization of those integrations, I think it does help us move faster and get better tools out to our patients. And as a very quick example around this, Smart Exam has to date screened more than 11,000 patients and treated them mostly for viral upper respiratory tract type infections and influenza. But all of those patients had concerns and questions about coronavirus. And by having those integrations available, we're able to get that process integrated into the clinical workflow, make it available to providers, and in fact, streamline their care delivery process so they were spending about 90 seconds of provider time per visit as compared to the 20 minutes that it would take to visit, interview, document, place orders, do all the things that they would need to do in other settings. So I think this is one of those inevitabilities in healthcare. And to be honest, for me, a lot of the questions that come to mind are, one, how quickly are we able to act on this? And I think that's a question I'm hearing from other folks as well. As these new regulations and the environment shift, I think that that's a really important thing for us to be able to respond around. The other interesting question in some ways is, why hasn't this happened sooner? Why haven't we seen interoperability sooner? And to me, it's one of those interesting questions, and maybe I spent too much time in healthcare, and perhaps become jaded by it. But I think one of the interesting challenges is that part of the reason why we haven't seen interoperability sooner is that in some ways it really does break the foundational business model of many healthcare delivery systems. If we want our primary care providers, or if we want our specialists to be tracking and in relation with our primary care providers, we can't acquire those downstream referrals. The way that we do that is by making it enticing to make those downstream referrals, by having all of the information from those visits in the EMR system that we've provided. They want to be on our instance of fill in the blank EMR system because that makes their care delivery process easier. And interoperability, making that data freely exchangeable, I think there is a societal good that comes, and I think healthcare delivery systems are increasingly seeing that value and the potential for that as we take on more population-based risk. And I'm hopeful that this actually accelerates the process, and we see not only these initial changes, but other ones that really catch us up as an industry to other industries around the standardization and interoperability that we'd expect from other places.
Well, thank you. Well, John, what do you think about that? What do you think also on the business model? You're a physician. Is this, what are your thoughts on this? And also, I would imagine that there are some challenges to this as well. I'd love to hear your thoughts on what are the upsides and what are the downsides?
Sure. So one of the things that I think as all clinicians can relate to as a challenge. While we appreciate conceptually, but day-to-day is tough, is around clinical decision support. Alerts has always been a difficult part in dealing with EHRs. And I think one of the sort of promises with interoperability is to be able to begin using sort of analyses that are conducted at larger scale, bringing those in more real time, having more dynamic forms of clinical decision support that better suit workflow. And I think that's one of the things just clinically is going to be necessary, because we pretty much have stalled maybe from like the late 90s to now in terms of progress as far as use and adoption of warnings and alerts. I think the challenges will continue to be a couple big things. From a clinical and workflow perspective, introducing, we have the capability to do machine learning and larger scale analyses, but we don't necessarily make those more useful or more relevant to individual clinicians. So there's a big gap between, hey, there's this incredible new technique and we can apply deep learning, 500 million, patients, and this is useful for you in the day-to-day. And so I think being able, as we're able to deliver more decision support, we need to think about the interpretability and visibility of that type of information. And then, I think another challenge will continue to be, while there'll be movement, the sort of use of local codes for certain things is still not perfected. That's obviously addressed in some ways in this rule, but it's still going to be a little bit of time before we have all the sort of medications and laboratories and all those data connected. So a lot of the pieces that are necessary to develop and run these predictive models are still going to require a little bit of finagling. So I think the challenges around semantic interoperability are still going to take a little bit longer to come into place. But I'm hopeful for sure about decision support as having a rebirth or renaissance in this new era. Yeah.
That's great. Thank you, John. Vicky, what are your thoughts, and how close do you think we are at managing and this interoperability issues and merging all the data and the structured and unstructured data and from various sources? That's valuable, right, to truly gain insights, right? I mean, what John is trying to get to also, right, is the renaissance in clinical decision support only really happens when it's truly personalized to an individual. But to do that, you have to have the right data set and train your model on the right data set. When do you think we'll be there?
Yeah, no, I liked where John was going with this, and I might take it in a slightly different direction. So I think one of the big benefits to having these rules, and I know it was talked about earlier today, even though this is not getting us to read-write APIs just yet, this gets us to that on-ramp. And that's truly what I am super excited about, because once we are able to provide patients their data, we can then facilitate a feedback loop where we are then getting patient-generated data from them, where we are, and also talked about earlier today, we're getting patient-reported outcomes back. So we're at the very beginning of that, but I think when you look down the road, there is amazing potential, and the area that I'm most interested in is how can we use patient-generated health data in the clinical environment to cut down on the clinician documentation burden? And how can we make sure that, we've got data that are contextualized and summarized in a way that clinicians can use it? And I think, as mentioned very eloquently earlier today, more data is not the same as more information. And how can we get to the point where we are providing clinicians with the necessary information to make those clinical decisions, as John mentioned? So again, I think this is the start, but if we can get this feedback loop going, we can get this co-production of health data, right? We're providing patients their data, we're giving them access from payers, from health systems, and then patients in turn can share data with us and really work on that true shared decision making. So a lot of steps to get there, but very hopeful that we are now moving in the right direction.
Well, Vicky, can I ask you? I'd love the panelists, for Ray and John also to chime in here. It's interesting. You see, we're only starting to get there, right? In my world, we have been getting there for the last 3-4 years, right? And now it's the I'd love the thoughts. Are we, is it true that we're only kind of starting to get there, or do you think that we're closer to the place where we can and are already putting together clinical decision support tools? Ray, maybe start with you.
Sure, happy to. That's our core business. In a lot of ways, taking in information from the EMR system, from environmental and contextual information, things like seasonality and patient location, patient-entered information through our conversational AI interview process, taking all of that information, and just as had been said earlier, and turning it into data, into truly actionable provider information. That is truly at the core of what we do and how we've made the care delivery process 15 to as much as 20 times more efficient. I had somebody tell me once the best EMR system would be the one that I never have to interact with. I think in a lot of ways, that's the goal. What is an EMR system? An EMR system is a complex set of databases that hold on to information, and if we're going to be honest, a pretty mediocre at best user interface over the top of that. And foundationally, that's what an EMR system is. And it was designed and built to optimize for billing. The question then is, how do we let them be that? How do we let them be that complex set of databases that we do need in order to manage and track patient information? But then how do we tap into that and change it from data into actionable, value-creating information, which includes things like provider decision support and patient education materials and workflow automation tools. All of those are things that need to get into those complex databases through these increasing interoperability standards. We can do that more quickly. I think that truly is the post-EMR world that we all should be thinking about. We came from the pre-EMR world where everything was on paper to the EMR world where everything was about getting up on a meaningful use certified EMR system. Now we're in this post-EMR world, and the question is now, okay, we've got this complex database, what can we do with it? Which is why I'm excited about the steps that this set of new regulations moves us forward around, but it also leaves me hoping that nobody sees this as the end point, but only the first step on what is a long but hopefully rapid journey forward.
That's great. John, what do you think? I mean, you have this unique combination of both a clinician and on the informatics side. What are your thoughts on it?
I mean, I'm probably overexposed to some of the informatics side, but I sort of agree that we are kind of moving there quickly. I think there's a lot of the pieces in terms of bringing in different types of data, particularly unstructured data. There's been a lot of progress, and not just. I think this is the shift that I'm really hoping we're now making. It's not just sort of like natural language processing, and here's a paper, and here's an AUC, but really NLP that can be applied more readily across lots of different systems and environments. We have one that we work at Georgia Tech called Clarity NLP. It's open source. There's other ones that are great as well, but really an effort to try to make unstructured data more amenable across multiple sites and more interoperable. I think on the omics side, we're seeing progress certainly in the bioinformatics sphere around doing that as well. And so I'm kind of optimistic that we will have less and less of a how do we even get started with this kind of project. We'll still have are we asking the right question? Are we analyzing using the right methods, and do we have a way of delivering that information downstream that is effective? I mean, that's not going to go away. But I think the sort of 40 to 50% of time that we spent just figuring out how to move structured data and unstructured data and connect these things up is going to be much, much less of a problem. And that's a near term, that sort of time is close to having arrived or has arrived already. So I'm optimistic about that. As you said, it's a bit of a bias because I Georgia Tech and I see all this stuff, and but will it make a difference to clinicians? That's the downstream. That's the, did we ask the right question? There's a great example, I think, of a really neat project at Stanford led by Nigam Shah out there. And this is a informatics consult that you can order via the hospital ordering system, just the way you would get a GI consult or a cardiology consult. You can order an informatics consult. And if you have a question about, I'm not sure which medicine is right for this patient because they've got some unusual constellation of things, they will run on, like 160, like all the Stanford patients plus 140 million patients from various other data sources they have, and generate, I think within 72 hours, a report. Here's the clinical question. here's the issue that was raised, here's what the data show, here's what we would suggest. And I think that's a really neat future of like, let's take the theory and make it actionable. And there's a consult you can order at Stanford to do that, which I think is fantastic.
Oh, that's great. And so who can access it? Just at Stanford in the hospital?
It's part of the hospital. Yeah, it's part of the, essentially the hospital ordering system.
Maybe they can white label it for others.
Yeah, I think there's a goal to do that.
So I do have another sort of general question for the panelists, which is, why isn't this rule a big deal? I love that Doug has put together this conference to discuss it. We all obviously think this is very exciting and a huge deal, and we nerd out on it. But I do wonder why isn't there more coverage? Why isn't there more discussion? I mean, in our world, and I think ultimately for patient outcomes and clinicians, this is a big deal, right? And business models as well, right? We talked about how that affects the business model. Why isn't this getting more coverage other than, the five of us that are very excited about it and a few others?
Well, hopefully some of our audience is excited about it as well. We'll keep our fingers crossed. But I'd say that there's two big reasons. One of them is it's more than 1,000 pages long, and that is a bigger span than most people's level of attention. And I think that the digestion of it will take time for people to really fully take that in. The second reason is that there are potentially other things in the media that are consuming people's attention. And the third one, I think, is that truly, like as I was saying earlier, it is, even for the folks in the know, I think this is a first step in a notably longer journey. And I think this is directionally exciting, but in terms of the actual destination, if we thought of this as the destination, I think everybody on this panel, my guess is we would all be, I won't speak for everyone. I would say I would be pretty disappointed if this is as far as we go. I'm excited that we've begun the journey, but the end is the place where I think we really start to see the value out of it, and there are many more steps. And I don't know what other folks' thoughts about that. I'd be interested. This is obviously an opinion question, not a factual answer.
Absolutely. Vicky, what do you think? You're nodding a lot.
Well, I'm quite surprised by the question, and maybe it's the space that I'm in, or maybe you'd have to be a patient that had trouble accessing their data when they really needed it. And I think the amazing patient stories we just heard on the panel earlier are quite telling. I think the majority of the public don't realize how difficult it has been to get their health data until they really need it. And I don't know, I think this is a big deal. I think it's getting a lot of attention. I don't know, again, it might just be the space that I'm in, but I think this is a huge win. And I do hope to see it expand, just as Ray mentioned. And I think one of the big pieces is expanding that data set. Right now it's the US CDI, right? But getting to a point where that gets to be even more data elements and making it even easier for patients to access their data. I think we have a ways to go, but I think this is huge. And I think that, the patients, again, that need their data and want their data, this is a huge win.
Yeah, it's a huge win, right? But it's not, the way it's described in the media, it's not as clear to the patients, right? The effect that it will have on them. So patients are, of course, and that's what I mean by that, right? So, of course, all of us and others that are in the space, of course, it's a big win for us, and we understand it's a big win for patients. It's a question, and it's actually an overall question too, what can the industry and what can practitioners do and clinicians do, right? Which raises probably a lot what your company is trying to do, I would think, is empower patients so that they understand in very simple language what this means for them.
And I think that that's actually closer to the reason why, at least outside of healthcare IT propeller heads like ourselves, there's probably less interest, is because they don't care. I had a surgeon tell me once that the two things that matter to a patient the most in any surgery are the scar and the bill, because they're the only two pieces that they see. And he also told me, so you better make them both look good. And I think if you think about healthcare informatics in the same way, everything that's happening around these regulations, they're inside. They're behind the scenes. They're things that patients shouldn't have to care about. In fact, a lot of ways, they're things that patients actually, if they knew the difficulty that is there, they'd be shocked. they'd be disappointed, they'd be frustrated. They don't even know that those difficulties exist because we've managed to duct tape and baling wire our way through the process before these things were in place. So I think that, that probably is also, I think you're right, that's a non-trivial contributor to why there isn't more general public acknowledgement and awareness of the impact. So. Yeah,
I would agree in terms of, I wouldn't expect my wife or my mother to be like, oh, I heard about this new thing, that it's not something that's going to be on the radar. But I do think that once the innovations that are built on top of it become more visible,
exactly.
They say, oh, did you know you could do, X, and that's pretty cool. So I think that that's really sort of the next wave of people sort of innovating on top now that we've got some stability will be visible and appreciated by the broader public. So.
And what are your thoughts? Because patients are tracking very carefully about a number of concerns that have recently been raised in terms of privacy and security of their data. What are your thoughts on this topic? Vicki, maybe you start.
Well, again, I think it's great that they're asking the questions. I think that's important. And I was actually going to ask John earlier if patients can also get those consults at Stanford. That would be excellent.
I think that requires a regulatory path there.
Yeah, but I think it comes down to, again, I think nurses are in a great position to do this as the most trusted profession. We already encourage the autonomy and self-management aspects of patients and their care. So I think being able to partner with patients and explain to them what this means, if they have questions about security and privacy, being able to answer those questions. So I think we have some work to do in getting our clinicians up to speed. I know ONC has already published some excellent resources that are there for patients and families to view on their own, but being able to discuss that with your provider is going to be essential. So I'm hoping that from an education perspective, not only in schools, but actually in healthcare organizations, that we'll be able to ramp up and cover those questions.
Great. John, what do you think?
Well, I think the security and privacy thing is going to be really interesting. I was at a talk by from the hospital side a couple of weeks ago, and they were saying, hey, we're obligated to provide patients access to their own data, regardless of the app that comes along. And so if someone comes and this is like, hey, I found this app on the, subway in Moscow, and it says, put your data here. If a patient comes and says, I want that added, put my data in, they have to do it. And it's very interesting because, of course, you can do that with your medical records. I could download mine, or I could get them and Xerox them and put them all over Midtown Atlanta, but I think there's just a different notion. So all of a sudden, the responsibility for that privacy and maintaining falls to patients in a different way, maybe than they've had before. And so that is going to be quite interesting. It also opens up, of course, so many possibilities where you can engage with patient populations rather than through the health systems in order to do interesting and novel work. But I think from a privacy perspective, we're going to see some people who, accidentally gave their data away, and that's going to have some complications.
Absolutely right.
Yeah, I would agree. The interesting piece here, I think, in some ways, is that it is a solved problem in other settings. So if you look at other countries, so France has had the carte vitale, which carries your full medical record, and every single citizen in France carries it around with them in their wallet. It's got a smart chip, and you plug it into a device, and there you have your entire consolidated personal health record and information available in the format that providers need it. So not a summarized version, but the full thing. So I think all of the points that you guys bring up are completely valid and things that we'll need to be thinking about. And by truly digitizing it and not making it directly accessible through a device, as they've done in France, I think we do introduce both more consumer accessibility, which I think is interesting and important. There also comes a different level of responsibility and education that needs to go as we consumerize the access to that data.
Yeah, Ray, so you've actually anticipated one of my last questions for the panel, and I know I
Oh.
see Doug and Christina are here, so that usually for me means there's like an Oscar music playing. So we're coming to the end.
We have time, and I think Victoria, did you have something on the last question? You look like you wanted to say
Yeah,
something.
so I do have a last one because actually Ray anticipated this question, which is we have seen this type of interoperability in some countries, like you mentioned, France, Finland, Israel, Estonia. There are a number of countries, right? We're not discovering something new and exciting here, and
Yep.
the first movers, if anything, compared to some other countries, we're probably about 15 years behind, right? And so, are there any
You're
lessons
being nice
in
by
any
saying
particular
15
country
years.
that you think that we should be learning from? I am. I mean, I don't want to somebody that's design epic on listening is insult anyone. But Ray, what do you think? Ray, Vicky, John, what do you think? What kind of countries come to mind?
I'd broaden it. I'd say that actually the United States, while we certainly have some aspects, I'll keep this super short since they're bringing out the hook, but I think the United States certainly has some aspects of our care delivery system that are truly best in class. I think we also suffer from a bit of hubris and an unwillingness to be able to look at other folks and understand what they've brought to bear to solve some of these problems, which means that we spend a lot of time rediscovering the wheel. And that's not just around interoperability, it's in a lot of places. So.
Well, I can't help but when you said 15 years, it's true. About 25 years ago when I was in Japan after college, I remember everybody had a little yellow card and they would carry it around and they'd see any doctor and they would just jot down the key elements. They'd go to the dentist, they'd go to any provider, and it was just like, oh, that's easy. You just have this list. And so I do think that the notion and the expectation that it's sort of this patient-owned thing is going to be one of the big sort of evolutions, like culturally, for us as a health system and also as the broader consumers. And so I'm not sure if there's a specific country I would think to, other than the fact that in Europe and other places where they feel like they own their data and they have their rights to their data. And that's somewhat different in some ways than in the US. We kind of know it intellectually, but maybe we don't act that way practically. So.
Yep.
Absolutely.
Yeah, I agree. That's a really good point, John. And I just also wanted to bring up, going back to the last privacy and security piece, I think, the items to keep an eye on, at least in this country, is the Karen Alliance and the trusted framework. So ensuring that organizations are, well-versed on that, as well as the work that Xertia is doing and the guidelines around mobile health apps. So we can, again, answer patient questions and be educated about the apps that the patients are coming to us with. So I think those will be important to follow.
Yeah, that's a great point. And Doug, do we have questions? Should we leave a few minutes for questions from the audience?
Sure. I think it's interesting. You all also have a background on the research side, and Luba, you'd be able to join in this. Maybe, by the way, your depiction was great. My mother and my sister are nurses, so I concur with your assessment, Victoria. This is a first step. I think that's the really interesting thing is that there's broad industry agreement that this is the first step that was needed, and we all united, and that first step has been taken under Don and others' leadership. And so I think Don, Anish, and others, and I think that's why we're so happy. And then it's what we do with it from here, which is what the consumers will see. So that's why it's nice to see the industry coalesce. The other interesting thing is there was a lot of work on payers and providers, but ultimately we're looking for other benefits, such as, in particular, bioresearch, public health, which we've touched on, but bioresearch. And John, you're at the CDC right now. You're in the middle. You are a participant in the NIH research networks. Maybe you could give your point of view on why is it important to move to modern data standards in the research side, and what do you see next? And then Ray, Victoria, and then maybe Luba, you can end because that's right in your wheelhouse.
Well, I would just sort of underscore, I think, a point that's been made right along, which is that the needs of agencies like CDC or like FDA to be able to identify patients with certain adverse events, certain risk factors, certain characteristics, whether obviously the current COVID situation, but with EVALI or the vaping incidents as well, is all about being able to go in and understand, what does a population look like, and it has to go beyond. Right now they get chief complaint data, and they need to go to the next level. So, okay, well, can we get claims or structured data? But of course, really where most of the information they need is in the unstructured data. And I think that what we have coming now really does enable us to put together, not just at the single patient level, but at larger population levels, the ability to look for these individuals. And I think it's going to both make the process more efficient for public health at state and local levels, but also more consistent at the federal level. So I think it's going to be a central part of how public health and other regulatory activities are done.
And Ray and Victoria and Luba, if you could just give a quick view from your standpoint, how you're thinking about it and whether that factors in.
I think John said it very well. I think in some ways it comes back to something that came up as an earlier theme in the conversation, which is this transition from data to information, and that's as applicable on the research and public health side as it is on the individual patient and care delivery setting. It's the same principles, just applied writ large rather than deeply personal. So I think, John, you teed it up very, very well.
Great.
Yep, and I would just add, I think the work with the payer APIs and the connection to the local HIEs and the bulk APIs, these are going to give us really new opportunities for population health, whereas up until now, there's been a lot of pilots and kicking the tires. And now if we can start to do some large scale studies, it's going to be super valuable. So I'm excited to see that move forward.
Perfect.
Yeah, absolutely, Vicki. I completely agree. And with John and Ray, just an added thing to everything that you were saying is that since this is a practitioner panel, is just to make sure that clinicians are involved in every single step, right? Because we will see and we already see a lot of companies coming from the tech side, right? Because now you have access to this. But in order to really truly train your data and data set correctly to draw proper insights, you need clinicians, and not just physicians, but nurses, people that are with patients day to day and see how how they're affected by different treatment. So yeah, that's an added component.
Perfect. Thank you all so much. And I'm really glad you all got to meet each other. We have the good fortune of knowing each other.
Yes. And if anybody has a great, NOP and a system that can figure out if my cough is a bad kind of cough or a good kind of cough, let me know.
Great. Thank you, Luba. Thank you all.